Hello, everyone, and welcome to Preemie Chats, a space where we connect, learn, and share stories about the world of prematurity. I'm Leah Whitehead. I'm the proud preemie parent, and I'm also a former journalist, and I'm happy to be your host today from Halifax, Nova Scotia. And it's such an honor to have you join us for today's Preemie Chat. Preemie Chats is brought to you by Canadian Premature Babies Foundation, or you may also know them as CPBF. It's a parent-led charitable organization dedicated to supporting families, advocating for the needs of premature babies, and providing the latest information and resources to help parents and caregivers navigate this journey. So whether you are a parent, a healthcare professional, researcher, or someone just interested in learning more about prematurity, you've come to the right place. Together, we're building a supportive community where stories are shared, questions are answered, new evidence is explored, and most importantly, no one feels alone. Be sure to visit our website. It's there on the screen, CanadianPreemies.org, and there you will find helpful resources, our latest projects. There are lots of free infographics and postcards that your unit can use. So check it out. Information that's written by parents for parents. And you'll find a community of people who are involved with Canadian Premature Babies Foundation who want to see our little ones thrive. If you're watching live today, I invite you to please join in the conversation. Let us know who you are, where you're watching from in the comments, and you can ask questions about today's content, and we will be sure to get to them during our program today. And if you're watching a recorded session, you can still reach out to us through our website. Again, that's CanadianPreemies.org. It is through meaningful discussions like the one that we're about to have where we advance practice and grow together. So again, let us know where you're watching from. It's always very interesting to see who is tuning in. You know, sometimes we don't think about our relationships as families with healthcare providers until that relationship becomes very important. And during pregnancy, birth, and the early days after, those relationships are key to a person's experience. This time in someone's life is full of big changes, and how connected and supported someone feels, especially by their care team, and especially when complications are involved in the area of preterm birth, it can really shape their experience. A lot of things can affect how someone feels about their pregnancy and birth, but one of the biggest factors is how they interact with the people caring for them. In this discussion today, we're going to look at what the research says about building strong, positive relationships between birthing people, their support networks, and healthcare providers. We'll also share some practical evidence-based ways to strengthen those relationships and improve outcomes in maternity care. To lead us in the discussion today, we'll be joined by Jennifer Jollymore. She is a clinical nurse specialist, or a CNS, on the birth unit at IWK Health and has spent 15 years in perinatal care. She is part of a 4-person multi-unit CNS team that provides seamless care across the women's and newborn health program for patients and families with complex medical or psychosocial needs. Jenn is passionate about improving birth experiences and actively promotes practices to reconceptualize birthing culture. She has experience co-leading quality improvement work with interprofessional teams. And outside of work, if that doesn't sound like enough, she has a very busy home that includes completing grad schoolwork and caring for her big blended family of 7 children, along with her incredibly supportive partner. Thank you for taking the time to join us here today, Jenn.
Thank you so much for having me, Leah, and thank you to the Canadian Premature Babies Foundation for inviting me.
I'm going to let you jump right into your presentation and hear the wisdom you have to share with us today.
Wonderful. Well, thank you for that great overview and intro. And you absolutely get some of the credit for that. I'll get into that in just a moment, but I'd first like to start off with a land acknowledgement. I am joining you today from Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. My friend and colleague, Sheila Mills, wrote a land acknowledgement in honor of the work we do in perinatal care that I will share now. We'd like to acknowledge the Indigenous wisdom that exists surrounding birthing, much of which was stolen through the genocide that was residential schools, colonialism, and destruction of Indigenous family structure. It is our hope that through truth and reconciliation, that wisdom can once again exist and be passed on through generations of Indigenous birthing persons and their families. I have no disclosures, no conflicts of interest. I do endeavor to use inclusive language throughout. That is a personal commitment of my own that I make to use a term that is inclusive of the most people. So whether that's gender diverse folks or even people who don't identify as a parent for various reasons, whether surrogacy or adoption situations. So you will hear me use the term birthing people most often, although depending on the research that I am citing, sometimes more traditional gender terms are used that I will reference when referring to those studies. So I'm very excited to be here today at Preemie Chats. Leah, as I mentioned, if it wasn't for you, I wouldn't have created this presentation in the first place. When you originally asked me to do this for the Parent Partner Summit that was held in November last year at the IWK, as I said then and I'll say now, I thought I was pretty knowledgeable about birth work between my years as a volunteer doula and then birth unit nurse. However, when Leah asked me to do this presentation, it did give me pause because I didn't think I had considered this lens on birth work previously. Spoiler, it turns out that this is actually at the core of the work that I do every day. I simply hadn't considered it in these terms. So it took me a minute to catch up with what Leah already knew about me, but I'm grateful for the opportunity to talk about such an important topic. Last April, my colleague Maxine Bernard and I hosted a conference here at the IWK called BirthCon. Our goals for this conference were to improve physical and psychological birth outcomes. This is incredibly important to me in my work. As a clinical nurse specialist, I routinely talk to people about their trauma from previous birth experiences. I hear common themes among my patients, including high rates of intervention, emergency C-sections, not feeling listened to by healthcare professionals, feeling pressured into making decisions. What my patients tell me is consistent with the literature, given that there are high rates of birth trauma affecting approximately 1 in 3 people. To fulfill our goals, we had a diverse offering of presentations over 2 days. Some examples I've highlighted in the photos here include the birth nurse, Mandy Irby, who spoke about trauma-responsive care and preventing birth trauma. You can also see the Collecting Threads quilt is shown here, and that was a community art project in support of perinatal mental health that a former IWK patient and local hobbyist crafter, Carol Rankin, began after her own experience with birth trauma. You can also see the collaboration here between nurse Tanisha Strachan and doula Liz Burns taking part in a supportive care and labor workshop facilitated by Nova Scotia's own Wanda Cox, who is well known in our local birth community as an experienced doula trainer, and featured at BirthCon as an evidence-based birth instructor. I love this photo because of what it represents and what we discovered at BirthCon, and that is when nurses and doulas join forces and work together, we have such incredible power to shift culture and change outcomes. Obstetrical violence is a term that has grown recently in awareness and refers to mistreatment from care providers towards patients during birth and is associated with birth trauma. When birthing people describe their experiences of obstetrical violence, they report things like restricted autonomy, coercion, feeling powerless, fear, dehumanization, and objectification, neglect, isolation, feeling invisible or uncared for, and that feeling of receiving technically safe care, though less than ideal. If we really think about what's missing from these interactions, it's clearly a relational approach to the experience. But exactly how do we build and nurture those relationships? A group of Australian researchers noted that in practice, collaborative care discussions all focus around the healthcare professionals involved and neglect the patient and family as collaborators. The researchers did a case study to identify things that enable patients and families to be collaborators through interviews and surveys, and they found several themes on experiences of collaboration. One major theme was around woman-centered or birthing-centered care. Things like continuity of care, when you know and trust your care provider, autonomy, knowing your options and having your decisions respected, communication, being able to talk freely and ask questions, and support for decision making. Another major theme that emerged was around the organization of care. So, a sub theme being at the systems level, it includes things like information sharing, such as doing a bedside handover between healthcare professionals, institutional protocols that were supportive, different models of care, as well as workload and capacity and demand. And at the culture subtheme, things that promoted collaboration between patients and providers included teamwork, task orientation, respect, power and hierarchy dynamics, and interpersonal skills. They were all factors that had an impact. I think it would be fair to say that there is a growing research interest in this topic of relational approaches to birth, since I found a fairly recent literature review that included 19 studies that all examined healthcare professionals' perspectives on humanized care during high risk pregnancies and birth. As many of you know, high risk pregnancies are more likely to be a negative experience for pregnant people. There were three main findings through this review. Finding one centered around open communication between healthcare professionals and patients, that open communication should be encouraged to develop the relationship, which will in turn promote informed choice decision making or shared decision making. The humanization of birth is possible through good relationships, and healthcare professionals used verbal and nonverbal techniques to build rapport, and moving away from a paternalistic approach also promoted humanistic practice. Finding two centered on interprofessional relationships, the authors noted that collaboration and networking across teams is integral to humanized care. They also stated that continuity of care is still important even when engaging with a broader multidisciplinary team. So clearly the relationships that we have as a healthcare team with each other are hugely important in a relational approach to care. And finding three, this likely won't surprise anyone in the audience today, but the authors found that there was an over-reliance on policies and protocols for this population, meaning that healthcare professionals were less likely to individualize care for high-risk patients. A quote from the author states that excessive reliance on rule-based and protocol-driven healthcare can lead to lack of concern for women-centered care and to emotional burnout for healthcare professionals who can no longer provide the kind of care that led them to choose their profession. So I think this is truly a profound statement that highlights the vicious cycle that patients and healthcare professionals can find themselves in if not addressed. So now that we've explored the topic of birth trauma and how relational approaches to perinatal care can help prevent negative care experiences and outcomes for birthing people, I'd like to share some examples of projects I and others have been working on, but I will frame these projects in a new relational light. As a change agent, my mission is to reconceptualize birthing culture. One of the ways I've actively pursued this goal is by co-forming a small working group a few years ago. We called ourselves the RBC team, not to be confused with the bank, and together we identified several priorities that we believed would help shift our birthing culture. As relationships go, forming this group was a pivotal moment for me. I was new in my role as a CNS, and there was a steep learning curve to taking on advanced practice nursing, and it really felt isolating at times. The RBC team provided the support and supportive working relationships that each of us in the group needed to make the changes we were eager to see. I am the only original member of the group that still works at the IWK, though. We've lost two members to retirement and another to primary care. However, I'm proud to say that our work lives on. Two of our initial priorities that RBC chose to work on are essential to relationships. The first priority was to make informed choice decision making the standard of care for birthing people, shifting away from the old adage provider knows best to one where birthing people, families, and their care providers can have open conversations about risks, benefits, ask questions, where birthing people and families are truly empowered to make decisions that are best aligned with their values and goals. This kind of respectful engagement would challenge the status quo mentality of, well, that's how we've always done it. One of our RBC founding members, Kelly Chisholm, is a midwife. Informed choice decision making is central to midwifery care, and we tried to find ways to embed that into the perinatal culture here at IWK. If you roam around our main campus, you may see some of the public screens displaying messages about choice versus consent and being the decision maker in your care, to name a few. And I've even had patients quote this to me when I've met with them. They read it while they're waiting for their appointments. And I am happy to share that we've been at this for a few years now, and while change doesn't happen overnight, I can confidently say that I have been seeing a shift. So, in order to ensure informed choice decision making, we have to promote really great communication practices. In a Dutch study, researchers used video recorded interactions between healthcare professionals and patients to find enablers promoting communication and collaboration. I think it's really important that they included enablers for both groups because if healthcare professionals aren't working collaboratively together behind the scenes, is there ever any hope that they're going to be inclusive of families during those interactions? No, it's a two-way street. So promoting collaboration and better communication benefits everyone. The ways of working together that they found included small talk, including personal experiences of the healthcare professional, providing reassuring statements, having an informal atmosphere. These things all made it easier to share. Small talk between healthcare professionals also makes for better professional interactions too. The researchers also found that using humor could strengthen relationships and helps put people at ease. Having familiarity with one another through things like continuity of care help patients and providers work together. This was also true amongst healthcare professionals. Being familiar with someone may help you to have trust in that person. Though I will point out that familiarity has been a challenge over the last several years due to the high rates of turnover in healthcare um, throughout and after the pandemic. Use of sight, touch, sound included things like eye contact, comforting touch, tone of voice, connecting with the baby. I know in my own practice that while doing something as simple as checking the fetal heart rate, I will also often address the baby during that assessment. Parents like it. And when we do this, we know that the fetus can hear sounds outside of the parent's body as early as 27 weeks. So we're including them. Nonverbal gestures were also a strategy. Simple things like giving a high five, sitting down at the bedside when rounding, all helped when connecting with families. And for the healthcare professionals, small acts of service like an unexpected coffee delivery helped promote collaborative relationships. Another RBC goal that is clearly relationship based is something called group prenatal care. And group prenatal care is just as it sounds. Pregnant people are grouped together by due date with about 10 or so other people. Instead of going to the hospital or community clinic for traditional prenatal or one-on-one appointments, the pregnant people meet together in a room for a couple of hours, learning from one another and developing connections amongst themselves. The sessions are facilitated by two healthcare professionals, usually a physician or midwife with a nurse or other allied healthcare professional. And not only do the patients who receive this model of care develop their own support networks of other parents with babies of the same age, care providers also get to spend far more time getting to know their patients than in a traditional model of care, allowing for deeper relationships to form between the pregnant people and their care provider. There's a high level of satisfaction from patients who receive this model of care, but also amongst the healthcare professionals who provide this model of care. Last fall, we were fortunate to have one of our obstetrical residents, Dr. Ella Vermeer, present at Obstetrics Grand Rounds on the topic of prenatal education in Nova Scotia and group prenatal care. I remain optimistic that group prenatal care will be implemented here at the IWK one day, hopefully in the not so distant future. So, how does the research connect group prenatal care to relationships? If it's not already obvious, we're going to look at some more research to tie it together. In the birth experience study, researchers surveyed more than 8,900 people about their birth experience in relation to the model of care they received. In this Australian study, the models of care looked at were public versus private and physician versus midwife. There was an open-ended question in which respondents were asked if they had any further comments about their healthcare provider. The 2,700 responses to that question were then analyzed for themes, and some of the highlights of the positive experiences people shared included feeling as though they were, had been striking it lucky by being fortunate enough to form a relationship with their care provider, even if they were in a fragmented model of care. Having a great provider, when providers go above and beyond to ensure continuity of care. Working within the birthing world. So this is where healthcare professionals themselves negotiated continuity of care through friends and colleagues by calling in favors. Having a student provider allowed for continuity of care when otherwise patients wouldn't have had it. And everyone's great. So they had positive interactions and felt well looked after despite having fragmented care. Some of the weaknesses or negatives identified by the participants: lack of continuity of care was the number one issue identified across the board. They felt let down postpartum. They were unable to access care. They had to keep repeating their story. This lack of continuity of care during birth, hello, now push, kind of meeting somebody just before you give birth. Other people experience a sense of anonymity, this sense of being in an automated system, lacking personal connection, dismissed connections, or experiencing the cascade of interventions. Their birth, they described it feeling like a production line. Others talked about being bound by policies and protocols. So when care providers were overworked and understaffed, there were excessive waiting times, and COVID had an influence. And we all know how detrimental some of those COVID policies were on families. They isolated some themes specifically from high-risk pregnancies, and those included people experienced what they described as dangerous fragmented care. They were made to repeat their traumatic history at every appointment, which we know is not trauma-informed. They received contradictory advice. I see this all the time when folks are talking to multiple specialists. And people experienced frustrations in moving to the high-risk model when they had previously been receiving continuity of care. So a big change in what they had been receiving. So overall, continuity of care was valued across all models of care, and they found that midwifery was the themes around midwifery showed that it was respectful, valuing client preferences and autonomy. Clients described it as empowering. Midwifery care was also associated with better outcomes. So continuity of midwifery care is just associated with a decrease in labor interventions, increase in spontaneous vaginal birth rates, an increase in birthing people satisfaction, and is cost effective for health services. And midwifery care also improved the involvement of partners and family. So for the birthing people in the study, it was important that their partner experienced confidence and trust in the relationship with the care provider in order for the birth to be a positive experience. The need to include the partner highlights the importance of having a family focus, which could lead to empowerment for the whole family. In another study out of Norway, postpartum people were interviewed after they had been assigned a midwifery student throughout their pregnancy and birth to ensure continuity of care. There were common features identified for the people interviewed, including having an established relationship with the care provider, enabled confidence and trust. These were all necessary factors for a positive birth experience. They had attention from care providers, having an individualized approach, included holistic values, and having a familiar person present, which helped to keep patients calm and comfortable during birth, as predictability can decrease stress. They also noted that there was a focus on relational processes throughout their care experiences, and people remember the emotional support from healthcare providers during their birth. Increasing relational confidence and quality of relationships are key elements in a positive birth experience. And finally, they noted that midwives can promote empowerment for the whole family. The clear theme from throughout these studies all center around relationships. Taking the time to have conversations together, get to know one another, and build a rapport over weeks and months is hugely important to birthing families. And when this doesn't happen, families identify it as the very thing that was missing from their experience and found ways to replicate it by calling in favors or being fortunate enough to have a student follow them. This isn't simply a case of you don't know what you're missing out on. These families were acutely aware. As I've mentioned, group prenatal care is one means to help build the relationship between patients and providers. The midwifery model is another means of developing these relationships, due in part to the amount of time allotted at each prenatal visit. Currently at IWK Health, midwives attend about 5% of the births, and they receive double the number of intake requests that they can accommodate each year, hence the hashtag. I know I've shared a lot so far about the relationships between birthing families and healthcare professionals. That is clearly my background. But let's remember a very important part of this whole equation: the baby in utero who was soon to be born. Last fall, I saw a compelling presentation on trauma-informed developmental care from neonatal nurse practitioner Isabelle Mayette, who works in Montreal. I thought it was interesting that Mayette described premature babies as a fetus who is in the wrong place, and how that description orients us in a different way of caring for that baby. I also couldn't help but notice how all of the trauma-informed developmental approaches to care could be applied in one way or another to the birthing person as well. How we treat the birthing person in labor and birth directly impacts the fetus. When the birthing person is scared, stressed, in pain, stress hormones flood through her body and are experienced by her baby through their connection. However, when birthing people are well supported throughout, have a calm environment, they feel safe and signal to their baby that same feeling of safety. Dr. Marshall Klaus was a childbirth advocate and conducted one of the first studies to evaluate the role of a trained non medical support person to accompany the birthing person and noted that these birthing people had shorter labors, better birth outcomes, and this study laid the groundwork for doulas. I'm happy to share that we have a strong and active doula community in Nova Scotia that work hard to support their clients and advocate for humanized approaches to birth. Throughout labor and birth, the birthing person and baby work together, a clear example of their relationship. The baby is an active participant and does not simply wait for the uterus to passively push them out. While we do have a high epidural rate here at the IWK, patients are encouraged to stay active and with frequent and upright position changes during labor. When the birthing person changes position or helps to open the pelvis with a peanut ball or uses gravity, the fetus will use the new orientation to their advantage, often rotating or descending, finding the path of least resistance through the pelvis. I want you to imagine this. A baby is born under peaceful conditions and are then placed in immediate skin to skin contact with their birth parent, making a calm transition to extrauterine life, settling out their breathing, staying nice and cozy, letting the oxytocin do its job to promote bonding and attachment between the dyad, giving baby the time and space to show when they are ready to try feeding. It's a beautiful scene that, as it plays out, sets both baby and parent up for success. This is considered the fourth stage of labor when the baby is born, but the placenta has not come forth yet. Protecting the skin to skin contact between the birthing person and the baby will help encourage the placenta and help to minimize postpartum bleeding. A truly reciprocal relationship between the parent and baby. If immediate and uninterrupted skin to skin care isn't the standard in your community at your hospital, I encourage you to ask for change. Separating birthing parents and babies at birth is often unnecessary and not evidence based. Encouraging the non birthing parent to engage in skin to skin care after the first 1 to 2 hours in contact with the birthing parent is also a supportive structural relationship between that parent and baby. Today, during this short time together, we have delved into the topic of relational approaches to birth, as well as looked at the evidence that helps to support these relational practices and approaches to birth. I think it's important that we continue these conversations and we continue pushing for these practices in our communities because we can see how truly foundational and even transformational it can be for birthing people's experiences, for their babies, for their support people, as well as for the healthcare professionals who care for them. As you can see, I've included the RBC mission statement here as well because I think it echoes what I've just summarized. So I'd like to thank you for your time and attention today. I'm happy to answer any questions or discuss anything that has come up to you around this topic. Please feel free to connect with me by email as well. Thanks.
Thank you so much for your presentation. You loaded a lot of information in there in a very good way. Thank you. And you know what? The beauty of the slides helps. You can see that, I don't know. I just think a beautiful slide just really adds to the presentation. So thank you. I can see there's effort there.
Thank you.
I wanted to start with asking about something that I've talked a lot about with families and even have experienced myself. And that is that as someone who birthed babies, for us, it's can be and hopefully is one of the most profound moments that we have as parents. And yet the comment that I hear a lot from families is, yeah, they see this every day though, the staff, the healthcare providers. It's something, it's part of their job. And so I'm wondering if you think it's important that healthcare providers kind of maintain the wonder of the experience, if that makes sense.
Mm-hmm.
And then I want to double barrel that question a little bit and say, if you do think it's important, how do you do that?
That's a great question. I mean, I know even after all these years, I still teared up at a birth, many times, right? I don't know if you ever lose the wonder, although certainly I have heard from many patients as well that maybe during like a booked C-section, it just seemed very sort of routine, and
Mm,
staff are chatting about their weekend plans, or and so for some families, they actually describe that as reassuring, like they know everything's okay because people aren't stressed, or they're
mm,
relaxed, right? But on the flip side, yes, if this is a transformational moment in your life, which it very much is, right? And you want to honor that um, birth experience, then you certainly don't want people chit chatting about their weekend plans, right? And so this is where it comes back to having that individualized approach, right? If I know how to best
mhm,
support you and meet your goals, then I can tailor my approach to you, right? Is how I describe it to the folks that I work with, because what's right for me is not right for you, right? What's reassuring to me what won't be reassuring to you. Um, and so we do that, right, by developing the relationships and finding out what people want. Because I certainly, and I know I've probably harmed people unintentionally, over the years before, better, you do better, right? But you get on autopilot, right? You're working under
mm,
stressful conditions, and you're going from room to room doing things without really thinking it through. Eh, in a critical way,
mhm,
and yeah, and so having that pause moment of people looking at reading a birth plan, or figuring out how to individualize that care, helps support that healthcare professional, because nobody comes to work wanting to ruin somebody's birth experience, right? And so we need to
mm,
have those communication tools in order to support that. um, that's why I'm a big proponent of birth plans. I know that they get a bad reputation amongst healthcare professionals, but they serve their purpose, right? Because if I read that, then I know how to approach you so that I'm not setting you up for disappointment, or that kind of thing. I don't believe that they perpetuate unrealistic expectations. That's a bit of a myth. I think that is supported by evidence. So that's sort of the way to I feel like navigate, that, because if somebody's really wanting that special experience, then the team needs to know, right, so that they can help honor that.
mhm,
I don't know how to answer the second part of your question, other than again, if healthcare professionals are supported and healthy and working under good conditions, then that helps them to be their best selves
mhm,
when caring for others, right? And
mhm.
it's a systemic issue.
Yeah.
Yeah.
And I love what you're saying about almost the function of the birth plan, because I know when I think birth plans, there were some things that we prioritized, but often families who have premature babies, we will joke and say, "Oh, the birth plan goes out the window, like, you don't even consider it." And yet, the way you're kind of speaking of the birth plan is more a almost a different function in terms of, like, what do you want the atmosphere of the room to be like, which is an amazing way to even think about, how what environment do you want your baby birthed in, as opposed to necessarily the ABC that we kind of relate to what a birth plan is. So I
Exactly.
love that.
Yeah, that very much came out. We did a small quality improvement project around trialing a new kind of hospital form birth plan template. And we surveyed healthcare professionals, and then we followed up with the patients to see how they liked it and what their feedback was. And um, sad to say, although not surprised, that the healthcare professionals were all very critical. Like, we're setting people up for failure, unrealistic expectations.
Mhm.
Um, these are problematic, and the patients, like, their satisfaction was like off the charts, right? They loved them because the things that they actually wanted to have control over were things that you can do regardless of what happens, right? Like, can we have some put on some music? Can we put on a battery candle? Can we, keep the
Right.
lights dim? Like,
Yeah.
it doesn't matter if you end up getting induced, or you end up getting an epidural and that wasn't your plan. Those are not the things that people are concerned
Right.
about. It's the experience, right? Yeah, how we got there.
Mhm. Beautiful. We have someone joining us. Her name is Sandy, who's graduated from nursing just this past spring. And so Sandy is asking, what is the best time to establish relationships with parents? And do you have any tips?
Yeah. So I think as much time as you have is the time that you establish the relationship. Sometimes you're meeting some people for the first time once they're in labor, right? And you have only that time to work with,
Mm.
or you have the benefit of meeting them prenatally and lots of time to build that relationship. But my first question after I introduce myself is always, what's important to you, for this labor and birth,
I love that.
and tell me a little bit about you and your baby. And they might kind of get confused, but they can often tell me some things about their baby even though they're not born yet, right? Their parents, every parent loves to talk about their child, right? So, um, yeah, and then you take it from there, right? So you follow their lead, and if there's things that you notice information gaps or things they're curious about, you can help fill in those gaps or direct them to more resources, and offer opportunities, to follow up with them. Yeah.
And I feel like those tips you kind of gave some communication enablers, I think you called them.
Hmm.
That probably, especially when you have a tight timeline, can help in developing those relationships.
Absolutely. Yeah.
I wanted to ask, I love what you said, and just it even like brought a picture to my mind of when you're checking fetal heartbeat and you talk to the baby who's not even born yet. And I thought, that's a great tip for healthcare professionals, just in, again, humanizing the birthing experience. But I'm wondering too, and is there something set up at the IWK already that does this, but how do you model that to people? Because that's a personal practice of yours, but how do we spread the word on something like that? I'm thinking modeling, but you also have some other out of box ideas that you've already presented today. So maybe you have something already in the works for that.
That's another great question, Leah. And this has come up in regards to other things, right? Because, in labor and birth, we all practice behind closed doors, right? And it's one-to-one care. So
Mm,
it's not, the old days of the NICU where it was open bay and everybody's learning from each other and modeling practices.
yeah.
We've never had that, right? You might, depending on who your preceptor is, have some modeling in that respect, but very limited to one or two individuals, right? Um,
Mhm.
so we ask that question all the time, right? And there is, some things that are, supportive. We have the new clinical mentor role that's been implemented at the IWK. So all of our inpatient units have a clinical
Mm,
mentor who's able to support staff in various ways, right? So that's one means of trying to help, develop practice and supportive practices and in terms of things like that. Um, and yeah, but it's very much a work in progress, right? It's that whole shifting culture
mhm,
piece and really reframing how we see that patient essentially, right? Because there's
mhm.
the pregnant person and the baby. Yeah.
And I guess things like BirthCon help with that too, when you can have that gathering space of people who, work in that field and can share more broadly.
Exactly. That was our hope with the workshops, like I highlighted on day two, where we had people sort of all learning from each other. And that, well, this is what I do with this, or this is how I handle that.
Mm,
And yeah, really powerful learning opportunities and essentially modeling there, right? Because people are kind of demoing how they do it or how they give their spiel or things like that.
mhm. I love the hashtag Nova Scotia needs midwives. I'm wondering, how do we get midwives? Is it a money thing, or why do we have a lack of midwives? And I would suggest, and you'll probably know more than me, that it's not just in Nova Scotia where we have uh, the need for midwives, but other provinces as well. I've heard families across the country kind of say how they've been on a wait list for this kind of care. So, what's your interpretation? How do we get more?
Yeah, it is a funding issue at the very sort of, basic, level of understanding. We need the government to commit funds and resources to growing our midwifery program. Um, why that hasn't happened is a bigger conversation, right? I believe it's how we value women's health, right, and how we treat or value women societally. It's a bigger issue around gender inequality. But again, like I said, it's another issue or another conversation. But yeah, why we don't have that funding is very frustrating for families who want to have a midwife for their care and can't get one. I often
Mhm.
hear from those families saying like, "Jen, is there anything you can do to help me get in?" I wish. I'm sorry. I've got no pull there, right? They only have so much capacity. Yeah.
Mhm. Is it something too, do you think, that can be promoted more within kind of the area of healthcare in terms of presenting it as an option for people to become midwives? Or is that, again, a separate issue from the need?
Um, that's a good point. I think, there's always that fine line of um, when you need the care providers themselves to drive the change because they're already, working in an overburdened system, and then you're asking them to
Mhm.
be the advocates on top of it. I think the
Right.
Association of Nova Scotia Midwives does a great job of, uh, getting their message out, right?
Mhm.
They have an active social media platform. They've done some media as well, interviews and things, but it's yeah, when you're busy, you don't, with clients, you don't have time to take on that advocacy piece. So it's a
Right.
challenge for sure. Yeah.
Mhm. You had talked about interprofessional relationships being important to humanized care. I think that's so interesting that it's almost like the work culture
Mm.
translates into patient care, or it does, I guess, not almost. And so I'm wondering, you kind of talked about um, the communication enablers or the building relationship with people that healthcare providers may work with. What do you think are the barriers to building those relationships? Because I know the healthcare providers that I know in my life are very relational people. And so you see, like, it's not necessarily a skill that people don't have, but it just doesn't always happen in the workplace and doesn't always translate into the care. So what do you think are some barriers that are preventing those relationships from being built in a way that provides great care?
Yeah, it is a struggle for sure. One thing that I did allude to in the presentation was that with the so much turnover, right?
Mm,
There isn't that opportunity to build those meaningful connections.
yeah,
Some people who've been here a long time, like myself, like refer back to the heydays of like when everybody knew everybody, and you didn't even have to ask for what you wanted. It was already, somebody was already doing it in an urgent situation, and um, so I think that's very much a piece of it, right? We're in a different, it's a different time in healthcare, right? People, there's so many opportunities for people and they can come get some experience and then move on, right? And we didn't have those opportunities even 10 years ago, right? The same opportunities weren't there
mm,
for travel and things like that. So we are working within a system that doesn't support retaining people, right? Our practices have not caught up with how to navigate this new reality, which I think really impacts again, like our ability to form those relationships. And not to say that you can't do it, but again, it's the culture, right? And so if you
yeah,
if you're coming to work and you think like, I don't know anybody, they don't know me, I'm not putting in the effort to get to know people, right? And so we as an organization probably need to prioritize the ways to bring people together outside of the unit, right?
mm,
to foster those relationships. And there are strategies around that in the evidence, like um, shared, not necessarily like journal clubs, but like debate clubs or things like that. It's still like work related, but not doing your day to day work. Um, and things like that did exist in the past year, but nothing, nothing stuck around post pandemic. Yeah, and so looking for those opportunities when we do things like shared education, we have great conversations when we have interdisciplinary education, but it's right now, like for example, we do that with fetal health surveillance. It's once every 2 years. Like that's not enough to get
Right.
people in a room together but
Yeah.
when we do it, it's magic, right? They're like
Right.
they're working through issues, they're like troubleshooting, they're like coming up with like solutions. It's amazing. Um, and but we don't have those recurring opportunities, but that we should. Yeah.
Chantel's joining us from Ontario, and she said, I think so much of this back to humanity ideas needs to start in school for all professionals. Thanks for that comment, Chantel.
Oh,
I'm
Chantel,
going,
yeah. Can I
I
just comment
know.
on that? Like,
Yeah, please.
I hear this all the time. Like, oh, it needs to be in the school. It needs to be in orientation. You pick the education, formalized education platform, and that's where it needs to live, right?
Mm,
And the problem is, once people start, in the care area,
yeah.
it's information overload, right? And we know that that shuts down our critical thinking and we try to assimilate as quickly as possible. So it doesn't matter what we learned in school, it doesn't matter what we learned in orientation. We try to adapt as quickly as we can so we can decrease our stress, right? Of being
Mm,
new, of not knowing what to do. And so I teach people really great supportive care practices in orientation. We spend a whole day doing it. And I can tell you after 6 months, like they're probably not doing the thing, right? Because they're doing what they've seen modeled, right? Yeah.
mm. Yeah, it really is, as you have highlighted, a systemic issue. And
Hmm.
that how do we, especially when the evidence points toward humanized care being beneficial, as I think it was your last slide said, beneficial for everyone.
Right.
It's then, this kind of slow chug up a hill against a system that's kind of been
Right.
set up in such a way that doesn't nurture relationships.
Exactly. I will say, like the newer, residents that have come and newer nursing, school graduates, like I do think it's getting more and more embedded into their education, right? Because I
Mhm.
don't see the same kind of attitudes, that you might see from more senior folks. So I do think there is a shift education wise. I just hope that it sticks around once they get here.
Mhm.
Yeah.
That real life experience and day-to-day life too.
Hmm.
Well, I'm going to leave our conversation at that today, unless you have anything you want to add that I haven't asked you about, Jen.
No, I think your questions have been very thoughtful and I appreciate them.
Well, I appreciate you and your knowledge and your wisdom that you shared with us today, and your just outside the box thinking on so many of these things. Like even the idea, I was like scrawling mad notes, but the group prenatal care, like just really thinking about how we do change culture. And it often requires us to think creatively, which I know when you're full out. In the workspace and at home, it can be hard to tap into that creativity. So I appreciate you and your problem solving and the RBC group. And I just hope that, this kind of uh, passionate, collective, coming together, coming up with these ideas, moving things forward. I just hope that that kind of catches on across our country and gives us prenatal and postnatal care that we can all be proud of. So thank you so much for joining us here today.
Oh, thank you again for having me.
And thank you, everyone, for being here, for being part of the conversation, for your questions and comments. It really does add to the experience that we have every Friday at our live Preemie Chat sessions. If you missed any part of today's episode or you want to revisit it, then you can find this episode and all past episodes on our YouTube channel and again at our website at canadianpreemies.org. And while you're there, again, explore the many resources and support options that are available to help families on their journey. As a charitable organization, CPBF relies on the generous support of people like you. Your donation allows us to continue empowering families of premature babies every step of the way. And together, we can create a brighter future for all preemies and their families. And speaking of creating a brighter future, if you follow us at all on social media, you've heard about this already, I'm sure. But November 6th, we're having the Little Lights, Big Hearts Gala. You won't want to miss it. And we're especially putting the call out right now. We are 75% at our goal for sponsors for this event. But if you know somebody who has a heart for preemies or wants to help families of premature babies, then this is the event to sponsor. This is our biggest fundraising event of the year, and it's happening on November 6th. It will bring together families, compassionate individuals, businesses, advocates, community leaders, healthcare professionals, philanthropists, all for an evening of connection and giving. And it will be a very special time. They even have a light ceremony that will be very special and meaningful and display the heart of CPBF. You won't want to miss it. So put that on your calendar and also spread the word because we need people to know about it, to buy tickets, and to sponsor this event. I want to thank you all for being a part of this incredible community. We'll see you next Friday at 1 p.m. Eastern Time for another live episode of Preemie Chats.